Hey guys, Alyssa here with the Old Not Weak segment podcast. Coming at you this month, talking about an article that I had just recently come across that's titled The Implications of Low Muscle Mass Across the Continuum of Care, which is a narrative review done by Prado et al. And I wanted to discuss this article because, one, it kind of talks about sometimes, when we've been doing our job for a while, sometimes we go through the motions. We kind of need a reminder of why we're doing what we're doing and why what we're doing is so important. It's not rocket science. It's not new news to us that muscle weakness leads to many different complications or can lead to a variety of disease progressions and negative things that can kind of complicate the health of many of our patients, especially in older adults. So I wanted to kind of discuss first what this article did was they looked at three settings. They looked at inpatient settings, outpatient settings, and long-term care facilities, and kind of the common disease progressions that they see and how muscle weakness plays a part. So I want to kind of go through each of those and then kind of explain how we can use these facts to kind of encourage our patients to kind of put into perspective why muscle weakness and muscle strength is so important and why we need to keep combating that to act as kind of a motivation, but also showing how if we can improve muscle weakness, we can improve many of these things. So it kind of highlights our impact a little bit more. So basically, most of us know low muscle mass is a predictor of poor morbidity and mortality and occurs in several populations. We're going to mainly target in the older adult population. So overall, this study looked at many different studies and kind of came up with a summary of the findings across all of those settings that I just talked about. So in an overall summary statement, they found that lower muscle mass is associated with outcomes such as higher surgical and post-operative complications, longer length hospital stay, lower physical function, and poorer quality of life with shorter survival. So, like I said, not rocket science to most PTs and most people, kind of in the healthcare realm. But if we dive in closer and kind of look at a little bit more detailed in our settings, so if we first start at inpatient settings, so having low muscle mass in an inpatient setting has been found that low muscle mass is an independent predictor of post-operative infections and rehabilitation care among hospitalized older adults. So they were looking at 65 and up. So associated with low muscle mass included general morbidity, surgical complications, reduced physical function, lower quality of life, higher inflammatory response after surgery, which we know can cause a variety of things. And it also plays a huge part in the discharge destination. So whether you're going to a rehab or a skilled nursing facility or home. And it can also be associated with higher hospitalization costs. So all of these things can be combated with muscular strength. And we know that, the longer people are in the hospital, the more at risk you are for rapid muscle weakness due to immobility, prolonged bed mobility. So if we look closer, so say patients with COPD are 3 times more likely to have low fat-free mass with obesity, so low muscle mass with obesity. They call it sarcopenic obesity, which is a term I had never heard of, but it's kind of interesting to think about. So with that low fat-free mass with obesity, so that sarcopenic obesity, you're likely to have poor physical performance. So they had lower 6-minute walk test distances and higher systemic inflammation. And we know that inflammation in itself can cause a variety of very negative health conditions. So then you look at, so the stress response to trauma induces the negative protein balance and resistance to anabolic signals. So this reaction, along with the physical inactivity, immobility, ultimately leads to paralysis and loss of muscle mass. So when you have, the prolonged immobility, along with this stress response to trauma, so, with any sort of injury or even any sort of, elective surgery, total knees, total hips, those kinds of things too, that is a trauma. So mobility is huge for these people because they're already kind of having those two extra variables along with immobility. So you look at people in the ICU. So up to 63% of individuals admitted to the ICU on ventilator support have low muscle mass. And this percentage is higher in patients that are 65 and up. So it's super important not only to mobilize these patients on ventilators because they are that much more at risk for muscle weakness, but also especially our patients that are 65 and up. And a lot, with the recent research that's been coming out about early mobility and things like that, we've kind of gotten over that bump at first of how, not to mobilize these patients and things like that. So we're kind of past that, hopefully, and moving in a progressive distance that way. But people may be hesitant to get patients up that are both on a ventilator and 65 and up. So this low muscle mass, then you kind of fall into that cascade that I had talked about previously. And all of those things, lower quality of life, complications, all those types of things. So you kind of go into that cascade of very negative things that we want to kind of avoid. So I thought this one was kind of interesting. In older adults, strength declines more rapidly than muscle mass. In factors such as muscle attenuation, metabolism, aerobic capacity, insulin resistance, fibrosis, and neural activation might be more relevant for physical function and impaired mobility and thus quality of life than muscle mass alone. So this is basically saying we need to kind of look at both strength and muscle mass to kind of see, is it really the strength that's declining? Is it the muscle mass, or is it both? So, perfect. Okay, so, which is kind of interesting to think about because we kind of think that they kind of coexist. But to think that, that strength declines more rapidly than muscle mass itself, so even if someone is not necessarily showing low muscle mass, they might still be weak. So we can't just assume that because people have, more muscle bulk compared to, a very, very frail looking person, that doesn't mean that they're strong. So that is also one thing that we should look at, during an evaluation and things like that, to not just judge based on muscle mass, but also to actually test the strength too, to kind of prevent, again, all these things that I was talking about. And then one study reported that slow walking speed, but not low muscle mass, was associated with increased risk of hospitalization or higher likelihood of short-term nursing facility stay in women 65 and up. So I thought this was interesting because it targets the muscle weakness does play a part, but it is also saying that muscle weakness isn't everything. So, we kind of have to look at, again, other variables outside of muscle mass, such as both strength, because strength is going to correlate with that walking speed, because usually if people are walking slow, typically it leads to an indication of decreased muscular strength and power. So that's in our inpatient stay. Now, a couple of the other ones, so in outpatient, they kind of talked a little bit about the same thing, the same disease progressions, and I can post the article too if you want to read the more detailed description. I did want to bring up one specifically, though, about the long-term care facilities. So it's one of the facts that they brought up was individuals with lower muscle mass had worse Alzheimer's severity, and individuals with sarcopenia had poorer survival. So a lot of times people think, people in, memory care, people with progressive Alzheimer's or worsening Alzheimer's, it's very, very important that we still continue to strengthen these patients. Now, if we could decrease the severity of Alzheimer's itself, that was automatically going to bring a much higher quality of life. If we could, add in one more variable to maybe help slow the progression of Alzheimer's, that would increase quality of life by a lot. So I thought this fact was interesting, and it's kind of one of those things to, help justify why you're doing what we're doing, especially, in memory care. It can be hard. It's a very challenging setting to work in. So we are making a difference. Basically, we are making a difference is what I want to kind of point out there. Because like I said, it is a very tough setting to work in, but it's also a very vital one, especially for that quality of life piece. And, people with Alzheimer's might be more apt and might be more rapidly progressing into some of these other healthcare things. So if we could begin to slow that progression as well, that could also make a huge difference for these patients. So then there's lots of other facts in there. If you want to find something more specific than the ones that I had mentioned. So went through all those facts, and then it kind of talked about treatment, not necessarily from a rehab perspective, just kind of as a healthcare field in general. But a couple of things that I found, one of them, so they did kind of still look at factual information, and one specific fact that kind of stood out to me was they were talking about in regards to rehabilitation and strengthening capacity, that cancer patients were found to have normal anabolic response to nutrition interventions, not differently than healthy persons, even after surgery. So we're talking about, it kind of delves into a little bit of the nutrition and its correlation with muscular weakness and its importance with muscular strengthening. So, and it also points out that patients with COPD, the anabolic response to nutrition is not different than that of healthy individuals. And what's important there is that if they have the anabolic responses, then they're able to build muscle and able to adequately use, protein and other nutritional aspects to build that muscle, so they have the capacity for strengthening, which I thought was kind of interesting, because sometimes we think about, are all of our patients able to build strength as a normal healthy person should? And so a lot of times we do question, do they have the same potential, especially those with, acute or chronic conditions, and then which if they can't adequately, use the nutrition and use all of these nutrients that they have and can't process that, then it kind of leads us into a quicker muscle loss. So what this is telling us is that they are able to use and able to show these normal anabolic responses, so they're able to, build muscle and kind of slow that muscular weakness. So they do have the potential, and which is where we come in to kind of give that strengthening piece in supplements with nutrition. So it kind of goes from here to talk about where do we go from here. So we have all of these facts and all of this information, and it talks about how we assess. Now, like I said, it's not specifically rehab focused. It mentions one test that I am not familiar with, but I did get a chance to look it up. It's called the SARC-F, SARC-F questionnaire. It's a quick and valid, it states, in older adults, but the psychometric properties of, these instruments may not be determined across all populations. So there is, kind of a need for a diagnostic tool to assess both muscle mass and muscle strength. And we have a test of muscle strength as far as there's been a lot of testing with grip strength. And, people are using, ultrasound and things like that kind of on a more clinical end. So in order to kind of be able to better assess, once we have all of this new progressing information, this article was from 2018. So they're kind of moving into a progressive of how can we better measure these things so we can better attack them and better prevent this growing muscular weakness. And one thing it did mention is, and I thought it was kind of interesting, so with the ICD-10 codes, there is one for, let me pull it up. There is an ICD-10 code for sarcopenia, and it's the M62.84, which has been used since 2016, and they're proposing that the creation of this code helps to better track and has a potential for growing research. So it helps to better enable development and reimbursement of these diagnostic tools as we can do more research and do more data collection regarding data capture from electronic medical records. If it could flag the ICD-10 code, we can look at death certificates, and then, with other system data sources to help kind of understand. This was talking about the health economics and then helping researchers access this information more readily to kind of progress the research towards preventing muscle weakness, because it's clearly evident that muscle weakness leads to, a lot of different things and drives up healthcare costs. And it's definitely something that we as PTs can help prevent. So one thing I found that was really interesting about this article and why I wanted to talk about it is, like I said, sometimes when we kind of feel like we're going through the motions, you're a seasoned therapist, even us new grads coming out, sometimes you get kind of lost in all of the logistics of the job and, things like that. And then, we kind of get, why are we doing this? And it's very nice and very motivating, to me at least, when we can look at the facts and we can see that muscle weakness, especially, one thing PTs are the best at is muscle strengthening, and one of the biggest interventions that we, kind of tackle. We know that muscle weakness causes other health complications in general, and we know that generally strengthening can help. Sometimes it's nice to find, those detailed facts stating, okay, we are making a difference in those patients with Alzheimer's. We are making a difference, and people with COPD have the capacity to build muscle strength, and our patients have the capacity to build muscle strength. So then we kind of look at, okay, if they have this capacity, we can prevent all of these things from happening, or at least try to slow the progression of them, especially in our chronically ill patients. So it kind of serves as a reminder of how vital PTs are in the healthcare, system in general and improving healthcare outcomes. We have such a vital role, and no matter what setting we're in, whether it's inpatient, outpatient, long-term care, we have a vital role, and we need to take advantage of this to continue to help improve healthcare outcomes in mortality and morbidity. We can make a huge impact on these things. So I just wanted to mention, some facts, especially on a Sunday night, getting ready to go to work on Monday. And like I said, I will post in the comment section below the article, because like I said, it does go into more details in each of those settings. So if you are, working in an inpatient setting, working in an outpatient setting, you can kind of go in and actually see more detailed instructions or more detailed factual information that might be more applicable to the setting that you're in. So I will go ahead and post that. And if anyone has any questions or anything, definitely let me know. And then one thing I did want to report. All right, so I also wanted to mention this episode is also sponsored by the Academy of Geriatric Physical Therapy. The AGPT works hard to provide us Geri PTs with high quality content to help advance our practice. This year's combined sections meeting, which is coming up very soon, is a great example of that. The AGPT is offering three-day pre-conference courses, offering 3 pre-conference courses in DC before CSM kicks off. This year, you can learn about the fundamentals of Tai Chi, how to apply a comprehensive approach to successful aging, and how to effectively manage kyphosis. Again, this is Alyssa with the Senior Rehab Project, the podcast for the community of rehab clinicians working to advance care in older adults. This is the segment Old Not Weak, and if you have any questions, feel free to let me know. Thank you.